right, good morning, everyone. Dr. Randall Gates, board-certified chiropractic neurologist, also a chiropractic physician at Gates Way to Health. And today we're talking about vestibular hypofunction. And we're joined by Kathy. Good morning, Kathy.
Good morning, everyone.
All right, so this is the next video in our sequence on balance and dizziness issues and disorders. We've talked about Debarquement Syndrome, we've talked about vestibular migraines, we've talked about Meniere's disease, we've talked about benign paroxysmal positional vertigo, we've talked about vestibular neuritis or vestibular neuronitis. And now we're talking about vestibular hypofunction because this is in the class of conditions where people will feel dizzy when they have an issue because the vestibular nerve is not working correctly. So that's what we're talking about, vestibular hypofunction today. And Kathy, was there anything you wanted to start off with?
Okay, I guess first you said dizzy, not vertigo, correct? So the room's not spinning, their body actually feels dizzy.
Well, with vestibular hypofunction, if it's unilateral, commonly they will have vertigo initially or episodically, depending on the cause of it. So if they have Meniere's disease does tend to cause vestibular hypofunction. And so those folks will have vertigo or vertiginous attacks. Lots of times in between, they will feel dizzy. Something like what we were talking about before the video started, ototoxicity. In those situations, an individual commonly will feel more dizzy, then they'll have vertigo because it's just kind of, it may happen suddenly, it may happen slowly if you're taking something like aspirin that causes ringing in the ears. And so it just depends on the cause. That's the long-winded answer. Yeah.
So what's the difference between unilateral and bilateral vestibular hypofunction?
So unilateral means one vestibular nerve is not working. Bilateral means both vestibular nerves are not working. So conditions like Meniere's or vestibular neuritis typically will at least start with 1 year, particularly vestibular neuritis. Meniere's disease usually starts in 1 year and can go to the other ear. Something like a medication is going to more commonly cause a bilateral presentation. Yeah.
Okay, so what causes this in the first place?
Well,
what are the causes?
The potential causes range from the ones I mentioned to autoimmune diseases can cause vestibular hypofunction. That article came out in 2014, published by, I believe, the author Chiarella, where she looked at a large proportion of Hashimoto's thyroiditis patients, autoimmune thyroid disease, and like upwards of 50% of them had vestibular hypofunction when they did the testing. So that's significant for anybody with dizziness. And that's why I've been saying for quite some time that if you have dizziness and no one can figure out the cause, you really need to go through not only a thorough workup for your inner ear, but a thorough workup for autoimmune diseases and hormonal function. Diabetes causes vestibular neuropathy. So that hasn't been talked about a lot. But it's a really, really important thing because diabetics, we all know, get neuropathy down in their legs where their feet will start to turn color and, you know, they get numbness and tingling and they just can't feel their feet. Well, that same process is actually happening throughout many parts of the body, including their inner ear. So looking at conditions like that, also looking at the antibiotic issue or what the medication history is. Have they taken antiviral medications? Have they taken antifungal medications? Antifungals also can cause vestibular hypofunction. So I think just that one little rant right there encapsulates.
Also head injury?
Head injuries can be a little more unusual. For a head injury to cause vestibular hypofunction, it would more be from the standpoint of maybe causing like a labyrinthine concussion is what we would term. There's also something called superior semicircular canal dehiscence, where you have your three canals. I'm pulling out the poster, Kathy. So you have your three semicircular canals, and you can see this one referred to as a superior semicircular canal. And the layer of bone, and actually you can probably better see it right here, is actually pretty thin. And for some people, and I've seen this in head injury patients, the bone will erode up here, and then you can get a leakage of fluid from this canal into this space. And that's called superior semicircular canal dehiscence. And these individuals tend to get dizzy or have vertigo with sounds. symptoms. So if that is you, you really want to pay attention. So if you say, somebody snaps their finger and all of a sudden I have vertigo, the room's spinning, or my husband turns on the car radio and all of a sudden I feel dizzy. Those are cardinal symptoms for superior semicircular canal dehiscence. So that would be head injuries on that topic. Also, vestibular schwannomas, also known as the acoustic neuromas. These are tumors that I'm not going to be able to diagram well there. So your acoustic neuromas tend to present with tinnitus or ringing in the ears. So if you say, hey, I've had ringing in my left ear and it's getting worse, just know that tinnitus is a really common problem, but anytime a doctor hears a patient say, I'm having tinnitus, maybe I'm having some hearing loss, we want to think of this vestibular schwannoma as a possibility. I'm trying to orient my fingers correctly. Down here in the brainstem, we can develop little growths on the vestibular nerve called vestibular neuroma or vestibular schwannoma or acoustic neuroma. And these tumors most commonly present with auditory symptoms and later can cause vertigo. So those are the other considerations. And lots of times when we take them out, then a person can develop vestibular hypofunction because of that.
Okay.
So those
are there things that folks can do with this?
Say that over again, Kathy. Sorry.
Is there things people can do at home to treat this, or can they prevent this in some way?
So in terms of prevention, and this kind of ties in with everything we've been talking about, when we look at the group of inner ear conditions overall, basically we talk about Meniere's, we talk about vestibular neuritis, we talk about benign paroxysmal positional vertigo, we're talking about diabetes affecting vestibular nerve function, we're talking about Hashimoto's thyroiditis. What can a person do? I think vigilance for what we're eating and our food sensitivities is important to think of. Why 57% of Meniere's patients have a gluten allergy. Why Hashimoto's has a heavy association with gluten and dairy peptides. So, we all like to think one-to-one. We like to think, okay, inner ear problem. But you have to take a few steps back, and that's where functional neurology is different from our mainstream healthcare model, which many of us are in and is fantastic for acute problems. But if you're going to think beyond the Band-Aid approach, and the Band-Aids can be helpful, I'm not saying that, but if you're going to think beyond the Band-Aid approach and what the root cause is, you have to take a few steps back. You have to be a detective. You have to look for the smoking gun. And so that's where Meniere's disease, 57% have gluten intolerances. Now we know Hashimoto's thyroiditis has a heavy association with vestibular dysfunction. Now we know that BPPV has a heavy association with Hashimoto's thyroiditis. So we're seeing all these things add up. And so what can a person do? I would say everyone needs to be vigilant of what they're eating, what their food sensitivities are, and what foods you're eating and how they're impacting your gut bacteria. Because these gut bacteria, 37 trillion of them, heavily affect our overall metabolism, our inflammation, and I'm sorry to say it this way, but it's affecting our probabilities of developing these other conditions, because why are we seeing the incidence of all these autoimmune problems exploding? In my opinion, I feel this is why. And that's based on a lot of research too. So we had a few questions come in, Kathy. We have a comment of type 2 diabetic for 30 plus years, sudden hearing loss in my left ear. I'm wondering if this is why my doc doesn't think so. No tumors, no pain, no ringing. Sudden hearing loss, that's interesting. Usually the issues with diabetes are more vestibular hypofunction. That's the research I've read. And I'm not diagnosing this individual, but when we talk about sudden hearing loss, we also want to consider autoimmune inner ear disease. That's another one. And that's typically associated on lab testing with elevated erythrocyte sedimentation rates. What is that? That's a marker for immune inflammation. And what about when you've been diagnosed with MDDS, maladive Debarquement Syndrome, brought on by cruise ship travel, thanks, dizzy, and always in motion movement? And I would recommend for this individual, Kathy and I did a couple videos on MDDS recently. I think it'd be good to watch those. Basically with MDDS, And just recapping for everybody who's joined, Debarquement Syndrome was originally described in individuals coming off of things like cruise ships, sailors coming off of ships. It's also described following airplane travel and driving in a car. There's also a spontaneous form of it where it just comes on. One of the characteristic features of MDDS is that a person feels like they're rocking or bobbing, and that rocking or bobbing sensation is helped when they get in something like a car and they're moving. MDDS has its basis in an imbalance in what's called velocity storage, which is in your brainstem a signal that perpetuates the inner ear signal. So your inner ear, if I spin you in a chair, is going to activate for like 7 seconds, and your brainstem is going to perpetuate that signal for like 30 seconds. And if there's an imbalance in that velocity storage, then people start to tend to feel like they're rocking or bobbing forward or backward, right or left, right forward, left backward, something like that. And it has its basis in your cerebellum, the nodules and the uvula, deep in this region, because that region of your brain senses whether your head is tilting or if you're translating one direction. So that's kind of the basic description on that. So I know I've gotten off topic. Kathy, what do we have next in terms of questions?
Well, we were wondering if vestibular hypofunction is associated with aging.
Yeah, and then you also asked me what people can do. So relative to the whole dietary piece, there's that. And you want to be vigilant if you're taking medications. What are some of the common ones? Aspirin is one of the common medications that's consumed that can cause ototoxicity. Other antibiotics include the aminoglycosides like gentamicin. Gentamicin is actually used to kill the vestibular nerve in people who have Meniere's disease. And they do that because they don't want this person whose inner ear is swelling and contracting to keep having problems. Other antibiotics that are not as commonly talked about but are documented include Levaquin and Cipro. So if you all of a sudden develop dizziness after taking one of those antibiotics, you probably want to pay attention to that. And I think we talked about the other causes. And then other things you can do basically include trying to engage your vestibular system with fixation of looking at something and moving your head or moving your body while looking at something. So if you've been to vestibular therapy, and they may have you walking a line and turning and twisting, or they may have you looking at a dot and shaking your head, or they may have you looking at a checkerboard and doing this with your head. Those are all therapies that people will do to help with vestibular hypofunction. What you can do at home, one thing that I'm doing is I'm doing a lot of my workouts on an unstable surface. So you can try doing bicep curls on a foam cushion, or overhead presses with 3-pound dumbbells on a unstable cushion. I'm not saying so unstable where you're going to fall over and hurt yourself. Not saying that, but basically trying to engage your inner ear like if you were on a surfboard. Those are great activities to help our brain stay youthful and to stay young. Okay.
And the brain can recalibrate itself for this kind of thing, correct?
Yes, it can. And that's where the cerebellum has the marvelous function of being able to adapt. So our cerebellum takes in the information of our eyes, of our inner ears, and of our neck to create this picture of where we are relative to our surroundings. And when we have a healthy cerebellum, typically we can adapt to a low-functioning vestibular nerve or low-functioning bilateral vestibular nerves. The problem I've seen come into play is that when we have vestibular hypofunction and then we also have a cerebellar issue or an autoimmune issue attacking the cerebellum, then we can't adapt as well. So yes, we can adapt, and if you're not adapting, then you want to look at the health of your cerebellum and get testing for things like gluten, thyroid problems, dairy allergies, dairy intolerances, things of that nature.
Okay. Did we get a definite answer on the aging thing? Does that come along more with the foods and what we eat and how we take care of ourselves, or is age a real cause?
Age is a real cause, and basically when they talk about dizziness and aging, there are a variety of factors. Basically, as we age, we lose hair cells in our cochlea. So that's why we tend not to hear as well. The vestibular apparatus does decline with age, but not as much as our hearing portion of the inner ear. As your brain starts to age and decline, it's like almost everything else we start to regress, so to speak. I don't know if everyone out there has seen those pictures of, like a baby becoming a child, becoming an adult, becoming later in life. And then we almost, like, by the time we're in the nursing home, we're in the same posture we were when we were a baby. And that's because those systems are degenerating in our brain. So our posture changes. So in terms of aging, what can we do? Postural exercises, trying to stay upright, trying to keep your musculoskeletal structure strong. That's a big thing, because they talk about muscle loss in the world of things like vestibular hypofunction and the dizziness that happens with aging. Like 30% of people over the age of 70 are dizzy. And certainly there are a variety of conditions, but basically deconditioning is a big piece of that. And that's something I so admire about you, Kathy. And I'm not just, trying to be exuberant here, but I mean, really, you're in fantastic shape. You're very active. And those are the traits that we really try to encourage in our patients, because if you're active and you have good muscle tone and you're pretty strong, that's going to help you to deal with something else that may affect your inner ear. And there are studies basically showing that as patients progress into Alzheimer's or minimal cognitive impairment, that their posturography responses, meaning their balance responses, actually decline. And believe it or not, your inner ear actually sends signals into the memory area of your brain associated with memory loss, and they're called place cells. And it's because, how many of you have driven somewhere and you just can't remember the directions anymore? Well, there's a lot of encoding in our brain of directions in our inner ear and our surroundings with the memory area. Does that kind of make sense? Did I answer the question?
It does. And what it brought to my mind was the fact that, you're talking about exercise, lift weights, do whatever, keep our structure or our skeletal structure strong and so forth as we age. And, I'm at an age I helped my grandparents and my parents and all these people get through their golden years. So I've seen all these changes that go through them. Mm-hmm. And just like you said, with the men who were more active and stuff, it was harder for them to do it because they hated losing all of that. But mm-hmm. As I told you the other day, I don't want to be the woman who can't carry the case of water in from the car, and I got to wait for my grandkids to come and do that for me.
Right, exactly.
But I had to do that for grandparents and so forth because they wouldn't do it. I mean, mm-hmm. They just got to a certain point where they're like, okay, my body can't do that anymore. And I think more and more, we're doing facelifts, we're doing everything else to look young, but we need to do the substructure work to keep young. And mm-hmm. when people say use it or lose it, there's nothing truer if we're not doing it. Right. And this is a point I wanted to stress for the folks. Think of that really nice car that you've had, your favorite car. You took such good care of it. You washed it, you waxed it, you gave it good gas, you gave it oil changes. You need to do the same thing for yourself.
Mm-hmm. It's so true. It's so true.
Don't be using cheap gas. Use some premium. Don't eat gluten. My grandson was here this week. We went for dinner. They wanted Italian. I was good. I got the gluten-free pasta.
Good.
But I did not think about the sauce. It said buttery cream sauce. And by the time I got home, the dairy in that blew up my stomach like a balloon. I asked my grandson and his girlfriend. They said, yeah, we had the same thing. I said, well, that's kind of a warning sign. You guys are in your 20s. Right. You have an issue with dairy, okay? Right. Don't be eating this stuff, or if you like having stomach issues, that's fine, but it's very uncomfortable. So be aware of it. Mm-hmm. And as we keep saying, food sources have changed. Everything has changed. It's not the same food we ate as children. The chemicals and so forth that's put on there is affecting how you feel. I saw one of the comments on there this morning that asked you about aging and this process, and then she asked about supplements and different things. Go online and listen to any of Dr. Gates' videos. He tells you, what to stay away from. And like anything else, like the car that's aging, yeah, you do need some vitamins. You do need some supplements. You probably need to speak with your doctor to make sure that you're not overdoing it, because overdoing it's just as bad as underdoing it.
Hmm. That's true. I like that. So
those are things to look at, but it's the same thing as like I said, putting premium gas in your car, I do take my vitamins and I do take the supplements that you recommend, Dr. Gates, because I know how much better I feel. Mm-hmm. And I know at my age, there's a lot of that stuff I'm not producing on my own. Mm-hmm. It doesn't function the same. It isn't absorbed the same. Besides trying to eat right and get some exercise. That's probably the best thing folks can do. And I know everybody says walk, but for people that are of an older age, walking is something that's good for everything. It's good for your lungs. It's good for your legs. It's good for everything out there. So don't expect it. It's like weight loss. You know, we keep waiting for that magic cure pill that we can take that has no side effects. It's going to make us thin and beautiful. And I watched this in my mom especially. She thought every time she got sick, she got better. So as she got really, really old and she had some impairments and she broke an ankle, she thought that thing was going to heal up and she'd be great. Well, when you smoke and you have diabetes and you have all these things,
right?
that's no longer there. It's not something that, I mean, it's definitely a wake up call when it happens and you go, oh, crap.
Right.
It's not going to heal again. What do I do now? Right. And the old joke, you know, I would have taken better care of myself if I knew I was going to live this long. Well, we're living longer and longer, so we need to take better care of ourselves.
We do, and it's those basic principles. And you know, some people have these habits earlier in life, and some people develop them later in life. It's never too late to develop them. You know, we work with these foundational issues at Gateswood Health and what we do with functional neurology. And, you know, that means dietary changes that are right for you. Not forever, but we try to figure out what foods are right for you. We try to figure out what exercises are right for you, physical as well as brain exercises, vestibular exercises. And so it's all those little habits that are going to lead people to being able to get their health back. That's what we find. Is it always quick? No, and we're all conditioned for that quick response, that quick treatment. It's not always that way, but we find that if we're slow and steady, lots of times we can get people back to health who have a variety of these conditions. And we had a question, Kathy, about what is the treatment for MDDS, and I can't really say the specific treatment because there is no one specific treatment. If you're looking for something like that, you may want to look up the work of Dr. Dai, D-A-I. They were out of Cedars-Sinai in New York. Unfortunately, I think both of the physicians have passed, but they have some literature published on things people can do at home that may help. But we see a lot of people who haven't necessarily been helped with MDDS, and we've had some pretty significant changes, and it's all based in getting to the root of the autoimmune issues. Getting to the root is the immune system attacking the cerebellum, getting to the root of what the velocity storage imbalance is in the brainstem, and how we can give somebody specific eye exercises that rehabilitate areas of the cerebellum. That's what we do. In my opinion, a lot of the stuff out there is very generalized. You're doing bilateral movement, and we try to do movement that's going to be specific for that person. One thing I was also thinking about, Kathy, is relative to how do we diagnose vestibular hypofunction. So somebody asked a question on Facebook last night about calorics. So calorics are where the doctor takes an air, basically it's like an air little thing, and you put warm or cold air into the inner ear. How does that work? In essence, here's our vestibular system. Here's our semicircular canals. When you inject air into the ear, it's going to warm up this portion of the inner ear, the vestibular apparatus. And when we warm up the vestibular apparatus, it's going to cause fluid to move in one direction through the semicircular canals. And basically, if you have a set temperature, like 44 degrees Celsius or 30 degrees Celsius, then you can gauge how that person's inner ear is going to respond to those temperatures. So one is the warm, one is the cold. And when you inject cold air into the inner ear, it causes the fluid to move the opposite direction. So that's the principle of caloric testing. And then you measure a person's eye movement in terms of nystagmus, and we grade their nystagmus relative to age-matched normals And that's how we figure out, does somebody have vestibular hypofunction on one ear or both ears? There's also the video head impulse testing, which is where a doctor puts goggles on the person, and then we move their head really quickly, and we see how their eyes move. If their eyes don't move appropriately and you see a little catch-up eye movement, then that can indicate vestibular hypofunction as well. So those are the two most commonly used methods to do that. There's also rotatory chair testing, where you get spun in a chair, but the chair has to be very much set and basically determine its exact velocity, and it has to be calibrated, so to speak, for that. And Kathy, did you have anything else this morning?
No, I think that tells us pretty much about the vestibular stuff. Have we covered pretty much everything to do with the vestibular nerve stuff?
Yeah, I think so. I think basically just recapping vestibular hypofunction, it can be one ear, it can be both ears. If it's one ear, you're more likely looking at early onset Meniere's disease or something like vestibular neuritis. If it's both ears, you're more looking at a systemic process, something like an autoimmune response. We mentioned Hashimoto's thyroiditis. Diabetes is now being acknowledged to cause bilateral vestibular hypofunction. If you see it in both ears, you want to be thinking, did I take an antibiotic? Did I take an antiviral medication? Did I take an antifungal medication? And then look at what that medication was, and then look online to see if that medication matches. Basically, the aminoglycoside antibiotics, as well as the quinolone antibiotics, quinolone, are not as commonly known, but are acknowledged in the literature to cause vestibular hypofunction. Those include drugs like ciprofloxacin, also known as Cipro, and Levaquin. And they're pretty commonly used antibiotics. So if that's you, then talk to your doctor about that. Have you been taking aspirin? Aspirin's known to have some ototoxicity properties. And also,
lots of old folks taking aspirin every day for to thin their blood. So that's something to think about. And
that can cause, definitely, if you have ringing in the ears, you want to talk to your doctor about, is your aspirin causing that? And really, anytime if somebody says you have vestibular hypofunction, you need to make sure you've had a thorough neurological exam, and you also probably want to say, hey, have I had some imaging in my brain? Make sure your doctor has considered that, because you can get tumors that grow on your vestibular nerve that can cause hypofunction. So all these factors have to be taken into account. Those are the major ones we've covered. And if you have vestibular hypofunction, then you want to go through specific therapy for your vestibular nerves. And those can include certain physical therapy activities, eye exercises. We have our own way of doing that in functional neurology, which we feel works the best for us and our patients, but everybody's going to have their own bias. So that's basically what we do. And keeping your musculoskeletal system healthy is a great thing to give your cerebellum some power to help you in the event that you develop vestibular hypofunction. Okay, so I think that's it.
All right, so we're going to start a new series next week then?
Probably. Somebody requested thyroid. I was trying to think if there's anything else in the dizziness world we need to recap. But yeah, I think it's good that we look at other things we should talk about. And yeah, I'm open to that. So whatever you're thinking, okay, Kathy, and whatever topics the folks are thinking about, we'll go with.
Okay. And remember, folks, send us your questions, and we'll make some things up to cover what you're looking into.
Perfect. All right, everyone. Well, have a good weekend, and we'll talk to you all soon. Okay? All right. So we're going to end there. We're going to end on this.